professor of medicine at Vanderbilt University's Autonomic Dysfunction Center, where she does detailed physiology research to unravel the mechanisms of POTS, orthostatic hypotension, and other autonomic disorders. She's a fellow of the American Heart Association and the American Autonomic Society, and she's a Dysautonomia International grant recipient. So we're looking forward to hearing an update this evening on her glucose metabolism in POTS research that we have funded thanks to your generous contributions. And with that, pass it over to Dr. Shibao.
Thank you. I hope everybody can listen to me well. I would like to thank Dysautonomia International for the opportunity to share our results, and also Lauren for all her work. My topic is autonomic regulation of glucose, and these are my disclosure. And there are a couple of specific topics that I would like to discuss throughout my presentation. First, I'm just going to do a brief review of the concept of glucose homeostasis, what is the incretin effect, how the autonomic nervous system regulates this glucose balance or glucose homeostasis, and what will be the impact in terms of, the regulation of glucose metabolism in POTS patients, as well as how it contributes to some of the exacerbation of the symptoms in patients with POTS after they eat. We call that postprandial worsening of POTS symptoms. All right, so I just want to do a brief review of some of the key concepts that I'm going to talk throughout my presentation. I will talk about carbohydrate, and I just wanted to let you know that it's 60% of the Western diet is compound of carbohydrates. And of course, if you break down this carbohydrate, we have glucose, that in layman terms is called also sugar. So I will refer to the sugar in a similar way to glucose. And I would like to talk about this concept of glucose balance or glucose homeostasis. And it means that your body, one of the main important work of your metabolism is to maintain this glucose level between the ranges of 80 to 100, and on an average 90 milligrams per deciliter when you stand up. In other words, if you rest throughout the night without any interruption, without eating in the middle of the night, and you wake up, normally, if your metabolism is working well, your glucose should be between 80 to 100 milligrams. Now, how this balance is achieved? Of course, one aspect of that is the fact that you are consuming glucose, you are consuming carbohydrates or sugars by, dieting alone, right? And the other important concept is that certain organs in your body produces glucose, such as the liver and the kidney in a very small proportion. So you have how much glucose you intake by your diet, and how much glucose is produced by your liver, and then how much glucose is absorbed or used in your body. And the majority of the glucose that is absorbed and used in your body goes to your muscle. All right, so let's just walk through the process of what happens when you ingest glucose. Imagine you're eating a cupcake. So you have a huge amount of glucose and also fat that increases in your blood. And that signals your pancreas to produce a hormone called insulin. And insulin is increased after you eat, and it goes to your peripheral tissue, usually your muscle cells and your liver, and it's being absorbed into these particular organs. And therefore, your glucose level that is increased because you are eating carbohydrates, it's regulated by being absorbed in your key organs, such as your liver and your muscle cells, to produce this glucose balance, to restore the glucose to a value of 80 to 100, 90 milligrams on average. So what happens when you don't eat? For example, you stop eating, let's say, dinner. Then your glucose level will decrease. So that tells your pancreas that it's time to produce a different hormone that actually is going to liberate or make your liver to release the glucose to your circulation. And in that way, also your glucose is maintained to a, a relatively narrow range. Now, it gets a little bit complicated, and I wanted to talk about this system called the incretin hormones, because part of the research that we have done here at Vanderbilt was focused on these particular gastrointestinal peptides. So when you eat, usually your food goes first to the stomach, of course, and then it's absorbed in the small intestine. So the small intestine releases two particular hormones, the GLP-1 and the GIP. So these are called incretin hormones because they are released in the intestine, in the gut, by K and L cells after they are in contact with carbohydrate, glucose, or fat, and then they are released in the circulation, go to the pancreas, and help the pancreas to release more insulin. And it has off-target effects. So in addition to release the insulin, it goes to your brain, it changes your appetite, it burns your energy, and make your your stomach to move. In other words, to release some of the content. So those are the incretin effects. So why am I interested in this system? So, and this is based on an observation that we have at Vanderbilt about, for treating our patients with POTS. And they always complain that after eating, they have worsening of these presyncopal symptoms, so feelings of fatigue, tachycardia, and so forth. And some of them, they have this hypoglycemia, which is that the blood glucose go below 60 milligrams per deciliter after they eat. And they have noticed that eating small meals improves their symptoms, and eating meals with less carbohydrate also improves their symptoms. And, I have heard multiple times from my patients that after they follow a gluten-free diet or a keto diet, which is primarily a low carbohydrate type of diet, they'll feel much better. So in this system, what is very important to understand is that the autonomic nervous system plays a key important role in glucose homeostasis, which is the ability to maintain your glucose within a certain range. So the sympathetic nervous system, the work of the sympathetic nervous system is to increase or promote an elevation in your glucose. So it can go to specific target organs, such as the muscle, for example. So what it's going to do is going to decrease the amount of insulin released from the pancreas, because if you decrease the insulin, then you don't absorb so much insulin, then there's going to be more glucose in your bloodstream. It's going to increase the amount of your glucose produced by the liver. It's going to increase the amount of fat that your cells release, and it's going to burn energy. It's going to burn energy. Of course, it's a balance. So the parasympathetic nervous system does the opposite. So what happened in states where this system is, altered? For example, obesity. Obesity, we know that predisposes patients to develop type 2 diabetes, and it has other, negative effect in terms of your metabolism. But in reality, when you become obese, there is another aspect that happens with the sympathetic nervous system, which is that it increases. So sympathetic activity is increasing obesity, and parasympathetic activity is reducing obesity. And we don't clearly understand why this happened. In part, we thought it was related to an increase in insulin levels, because insulin also promotes increased sympathetic activity. But what happened with obesity is that because you have this disbalance, then your glucose homeostasis or your glucose balance is altered, to the point that, the increase in sympathetic activity may predispose you to a state in which your glucose level is elevated. And that's one of the initial steps for the development of diabetes. So, but what we have recognized at the same time is that if we move our studies of physiology from obesity to patients with postural tachycardia syndrome, we know that in patients with postural tachycardia syndrome, we also observe an increase in sympathetic activation. So we call that, in clinic, hyperadrenergic POTS. We know that, the majority of the patients presenting with with symptoms of portal tachycardia syndrome have some degree of elevation of sympathetic activity. So this is a study that was done at Vanderbilt with 56 POTS patients. And what we saw is that, at least 80% of them, like 44 out of 56 patients, had at least one of the 4 criteria that we recognize right now that, tells you that the patient has increased sympathetic activity. Like what, for example, that like norepinephrine levels over the value of 600, or a significant increase in your blood pressure when you stand up of more than 20 points, or changes in the Valsalva maneuver. This is some of the tests that we do in clinic that show us that there is increased sympathetic activation. So, and all these different type of patients that we see, patients with decreased plasma volume, patients with some degree of neuropathy, or patients who have just hyperadrenergic activity of unknown etiology, they all converge to one single denominator, which is, or unifier, which is increased sympathetic activation. So there you have a complex system that require a good balance of your blood or your glucose, and at the same time you have a disease like POTS that is associated with increased sympathetic activation, which we know may have some deleterious effect in terms of how your body balance your glucose levels. And sometimes the degree of increased sympathetic activity that we see in patients with POTS is much, much higher than the degree that we observed in obese patients. And this is, once again, the increase in sympathetic activity, it's present independently of what the different criteria that you use, which could be, blood pressure elevation upon standing, plasma norepinephrine upon standing, and the Valsalva maneuver. Now, as I said before, I became very interested in this area for 2 reasons. One, because we don't have a very good explanation of why some of our patients with POTS have worsening of the postprandial symptoms. And 2, because I was initially studying patients with that were obese and became prediabetes. And we published a paper some years ago in Hypertension saying the increased sympathetic activity in obese people predispose them to insulin resistance. And of course, seeing patients with POTS with increased sympathetic activity, the question that I have in my mind was whether this increased sympathetic activity actually predisposed also to some metabolic alterations that can put you at risk for diabetes. So this was a very simple study. We just evaluate differences in glucose homeostasis surveillance between POTS patients and normal controls and patients with obesity. And we also determine the hemodynamic changes in these patients. So we studied 3 groups of patients, POTS, healthy and obese. And we exclude patients that already have a history of type 2 diabetes. Of course, we didn't want to study patients that we know they already have a metabolic disorder. And then we did what usually a patient receives when they are pregnant, for example, is a 75-gram oral glucose tolerance test. So we ask the patients to drink the sugary drink as fast as they can. And then we combine this sugary drink with acetaminophen, which is paracetamol is the compound that is included in Tylenol, for example, but we use the generic acetaminophen. And the idea for that is to be sure that the absorption of glucose was similar between patients with POTS and healthy or lean controls and the obese. So in addition to that, we measure POTS hemodynamic, which is we wanted to see what the meal does in terms of the blood pressure, the heart rate, the stroke volume, the cardiac output. This is all the important measurements that we obtain to try to understand, what can explain any problems like tachycardia or hypotension. So we measure all of that at baseline, which is without any sugary drink, and at 30, 60, 90, and 120 minutes after they drink their glucose. Okay, so this is, this was, for us, it was very surprising. We're going to talk about POTS, postprandial hemodynamic in POTS patients. So what you can see in the left is what happened with POTS patients before and after they drink the glucose. And on the right is what happened with healthy normal controls that are matched by age and by body mass index. In this case, both groups were lean. So in other words, the BMI, which is body mass index, was less than 25. So when the patient is supine, and this is POTS patient, the heart rate is about 70. And of course, they stood up and the heart rate increased significantly. And then they lay down again. And now after drinking the glucose, the heart rate was a little bit elevated. And then when they stood up, the heart rate increased significantly. And I was very amazed because some of my patients, just by drinking 75 grams of glucose, and we call that glucola, it's just like two bars of chocolate. So the heart rate went up to about 130 beats per minute compared to fasting conditions. And when we did the same in normal controls, the heart rate was very variable, and it increased in some of them. It was during fasting conditions, but it didn't increase as much as in patients with POTS. But then when you look at the supine and the upright heart rate, the upright heart rate increased a little bit, but the highest number that we saw was 110 in the healthy controls. And so there was a staggering difference of what just 75 grams or 400 kilocalories of glucose does to a patient that has POTS versus a healthy control. So no wonder why a patient with POTS has significant postprandial symptoms, because the heart rate just didn't take off after just a simple sugar challenge. So when you look at the baseline characteristics of the patient that I studied, and we enrolled about 13 patients that had POTS, and then about 13 controls. So the supine heart rate was about, as I said before, 70, and around 10 minutes after they stood up, it went significantly up to 120. And of course, the majority of these patients have hyperadrenergic activity because the plasma norepinephrine went from supine to upright from about 300 to more than 750. And remember, the criteria for hyperadrenergic activity is a plasma norepinephrine during upright posture of about 600. And this did not happen in the control. And it was baseline fasting conditions. So then we look at all the different parameters that are important to regulate your glucose levels. So we talk about glucose, we talk about insulin, and in addition to insulin, we measure C-peptide. C-peptide is the pro-insulin, so it's first released before it's cleaved, and then it's converted in insulin. And also we look at the acetaminophen level, which is, the substance that we put in the glucose so we can trace the absorption. And, the reason why we did that also is because several of our patients complain of changes in the gastric emptying. With the acetaminophen, we measure the absorption of the glucose, and as a way to try to understand whether the differences that we saw during the evaluation were related or not to changes in the gastric emptying or not. So the absorption is tied to the gastric emptying. Of course, if your stomach cannot move, then it cannot supply nutrients to the intestine, and it cannot be absorbed. So that's the reason why we measure acetaminophen. And what we found is that in patients with POTS, and these are the blue lines compared to normal control, which are the grays, there was a significant increase in the glucose level, as expected, right? So you drink your glucose, and then within 30 minutes, then it just became absorbed. But one of the things that we found very interesting is that when we look at the C-peptide, at the insulin, the levels in patients that have POTS, in POTS patients, were very elevated. And we see these in patients that have a condition called insulin resistant, Why? Because even though your insulin is higher than your normal, your glucose is normal. That means that there must be a problem for your glucose to be absorbed into the muscle, because despite you have been traveling with the same amount of insulin, it does not drop. Your glucose level do not drop. So if our patients with POTS will be, insulin sensitive because of the amount of insulin that they release into the circulation, the glucose level should be low. And in some patients, that may happen because some of our patients with POTS develop some sort of, reactive hypoglycemia, where, they by just eating a high carb meal, the blood glucose crashes. And I think that these are the patients that probably has an increased amount of insulin secretion, but they are sensitive, and therefore the normal response will be the glucose to drop. This is not normal response because the glucose is not dropping, even though these patients releases a lot of insulin in the circulation. And this is not related to an absorption problem because the acetaminophen level was similar between POTS patients and healthy controls. So, but what happened with the incretin? So we talked about the incretins at the beginning of my talk. So the incretins are released after you eat a meal, right? And when they are released, one of the things that happens is that within 30 minutes, there is a peak of GIP and GLP-1. But they both supposed to go up to the same level. They're both supposed to go up at the same time. But what you can see here is that in GLP-1, the kinetics, in other words, the changes in the GLP-1 levels are very similar between healthy controls and POTS, whereas GIP, which is another of these incretin hormones, is excessively elevated in POTS. So what does GIP does? And these are the incretins. We talked about that before. When you eat, the incretins are released. And these incretins go to the pancreas and tell the pancreas, release more insulin. So what we thought was that maybe this isolated selective increase in this particular hormone is causing this increase in your insulin and your C-peptide. So we have a link between what we see in the insulin C-peptide changes in after the glucose intake versus, what we see in terms of the release of these hormones in the gastric circulation, the gastrointestinal tract. And why is that important? It is very important because if you look at the literature about GIP and GLP-1, one of the main tasks that they have is to change the circulation of all your major splanchnic organs. And splanchnic means all your gastrointestinal organs. So if you were to measure, for example, the flow in this particular artery, the superior mesenteric artery that gives, a blood supply to these organs, you will see that there is a dilation, there is an increase in the blood supply. And of course, if you eat and you are secreting this GIP, then what happens is that you're going to increase the amount of, blood supply into the splanchnic circulation. And by the time you stand up, if you initially have a blood pooling in your abdomen, it will be much, much more when you stand after eating. And that's what we think is a potential explanation for the fact that a lot of our patients with POTS have an exacerbation of the postprandial and the tachycardia after just a single sugar challenge or glucose challenge. And we were right. When we measure different type of, hemodynamic, in other words, parameters that are important to explain how your blood pressure and your heart rate changes, what we observe is that if you see POTS patient versus control, the POTS patients have a significant increase in heart rate compared to the controls, but the stroke volume, and the stroke volume is the capacity of your heart to pump blood, is extremely decreased. And that part of the reason why it's extremely decreased is because probably the blood is sequestrated in this splanchnic circulation that is expanded by the fact that there is an alteration of different gastrointestinal hormone secretion like GIP in our patient with POTS. Now, if you try to look at the time-dependent changes in your heart rate versus the secretion of GIP, which is this hormone that I'm very interested in, you can see that it peaks at 30 minutes and it goes with an increase in the heart rate, and then the heart rate continues to go up 90 minutes after the ingestion of the meal, and as well as the GIP level. So there is a time-dependent increase between the GIP secretion and the heart rate upon study. So what is intervention? So one of the things is, why are we doing these studies? Because I mean, at some point we want to understand the physiology to treat patients, right? So so definitely eating small meals throughout the day will help to reduce this significant increase in the GIP. Eat meals rich in proteins because they are not so much trigger, the release is not triggered by the consumption of proteins like steak, for example. And you know, keto diet and look at the gluten-free diet actually works, I think, is because you're eating less carbs. Now, in terms of therapeutics, and this is something that that we are working on right now. You know, we talk about the postprandial effect of on tachycardia and presyncopal symptoms in POTS, but if you think about it, I mean, our normal dietary pattern is that you eat 3 meals a day, and in between you eat snacks. So the majority of your day you are in the postprandial state. So even though we think, well, it's attached to the meal, think about it. I mean, you have to eat. So eventually, all these different challenges you do when you eat your breakfast and then your snack and then your lunch and then your snack and then your dinner, all of that is going to amount a significant response of these GIP hormones that at the end is going to explain, you know, a significant part of your tachycardia during the day. So one of the things that I found in the literature was the ability to block this GIP with a medication, and the ability to maybe reduce the breakdown of complex carbohydrates with a common medication used for diabetes. And those are the therapies that right now I'm working on, see if that improves some of the symptoms and the postprandial hemodynamic changes, the tachycardia and so forth in patients with POTS. This GIP antagonist that I'm working on is this particular compound. We're trying to see if we can synthesize this in the US. It was already being tested in humans in Copenhagen. And the interesting thing is that 2 weeks ago, with Dr. Hasper in Copenhagen and Vanderbilt, we sort of filed for a grant to the NIH to try to use this medication in our patients. Now, on the other aspect, I talk about, you know, the postprandial changes on your symptoms, but what happened with, you know, the metabolic component that we see affected in patients with POTS? So what I did is I look at the postural tachycardia, a patient with postural tachycardia syndrome, and obese women that are healthy, that do not have diabetes. And I plotted all the different results in terms of, you know, how they behave after they drink the glucose. And as you can see, and these are the red are POTS patients, and the black are normal controls. And then the red are here the obese women. These are obese women. These are lean POTS patients, and these are the normal control. So they both have the same axis. So I just want you to compare these. If you can see this, definitely the POTS patients are very similar to the obese women, even though these POTS patients are lean. So look at the BMIs, 25, and in this group, the obese are about 35. So we're talking about 40 difference in pounds. And in this group, in patients with postural tachycardia syndrome, if you use the normal cutoff values for pre-diabetes, 50% of the patients with postural tachycardia syndrome have impaired glucose tolerance, and 30% in the obese group. Now, when you look at the glucose levels in terms of, you look at the glucose levels in the POTS patients and the obese control, these two are superimposed. In other words, I mean, even though the POTS patients are lean, they be with a BMI of 25, they behave like an obese person with a BMI of 35. And what it's very interesting as well is that if you check just the fasting glucose levels, without eating, okay, POTS patient has normal fasting glucose level, whereas obese patients or obese women have higher fasting glucose level. So how can you explain this? The problem with the patient with POTS is not, the fasting glucose, which is one of the main screenings for diabetes. You just take fasting glucose. The problem with the patient with POTS is when they are challenged with food, when they are challenged with glucose or with lipids. Then is when you can unravel this insulin resistance that they have. And of course, I mean, in addition to the problems of having an altered metabolism in terms of, glucose metabolism, having an excessive tachycardia after they eat, there is also a significant degree of gastrointestinal symptoms after just a simple sugar challenge. And we sort of quantify some of them during our trial. So what would be the relevance of this? So normally, this is just, a graphic that you can find in any publications. You will see that over time, a person may gain weight or has susceptibility to have diabetes, and therefore the insulin resistant subject, they will increase, but this compensated by the fact that your pancreas is secreting more insulin. So at the end, your glucose will be normal. It will be at some point that the pancreas is not going to produce enough insulin, and then it's when your glucose start going up, right? And that's what we call impaired glucose tolerance, which means that your glucose is elevated after a glucose challenge, because your body either cannot absorb it or because your pancreas is not secreting more insulin to help absorb the glucose. And then if this is not corrected, then you will end up developing type 2 diabetes. So if you think about an obese person, the obese person go through all these different phases, right? Unless they lose weight. But a patient with POTS, I mean, they are already, they are not obese. They are lean, and even though they are lean, they start having impaired glucose tolerance at the same level as a patient who is obese. So the time frame between impaired glucose tolerance to type 2 diabetes will be shorter in a patient with POTS compared to a person that does not have POTS. So what is the mechanism for these, changes in your glucose metabolism? We think it's a disbalance between this excessive sympathetic activity. It could be possible that there is an impaired insulin secretion from the pancreas, or the impaired gastrointestinal hormone secretion, or maybe the production of glucose by the liver is affected, or the muscle does not uptake glucose as it should. And those are, questions that needs to be answered to better understand what is the abnormality underlying these observations in terms of, the impaired glucose tolerance in POTS patients and the postprandial worsening of their symptoms. So the significance is that we found, thanks to our preliminary study, that a lot of the postprandial symptoms and the tachycardia in patients with POTS is related to a selective increase of this GIP hormone. And thanks to that, we actually are after trying to block this GIP secretion with 2 different therapeutic interventions. And in the future, I hope that could become some translate into better therapy to patients with POTS. The other thing that we understood is that there is impaired glucose tolerance in patients with POTS, and it has a very distinct pathophysiology. It's not linked to the usual, increasing weight that we observe in other people. Conservative measures such as weight loss may not alter the disease progression because you are having impaired glucose tolerance even though your weight is normal. And measures such as regular exercise could be different to implement because of the underlying disease. Especially with POTS, sometimes it's hard for them to exercise. And the risk of type 2 diabetes may be higher in patients with POTS with impaired glucose tolerance. Given the fact that POTS affect young people, so and young people start having impaired glucose tolerance early on, your timeline to develop type 2 diabetes may be shorter. We don't know this, but that's just a hypothesis. And we need to understand what is the mechanism underlying this impaired glucose tolerance in patients with POTS to better provide treatment options and that are focused not only to treat the symptoms, but to slow the progression of type 2 diabetes in this population. And with that, I just want to thank everybody for listening to my talk and all my colleagues who have worked in this field. And I will take any questions.
Thank you so much, Dr. Shibao. There are a zillion questions because that was such an awesome talk. And I know for patients that are hearing this, or caregivers, or even other clinicians that are tuned in, this is such a new topic. No one's ever really talked about this before in POTS patients, and it's sort of a revelation. I know that when you first told me that you had some of this preliminary data, I was like blown away. I was like, wow, this is something that's very tangible in POTS. It's not every day that we find very tangible biological mechanisms that might be amenable to new treatment approaches. So it's pretty exciting research. We've been very happy to support you with a grant for this, and hope that anyone listening who's kind of excited about this potential new treatment pathway in POTS, if you have the ability to make a contribution, hook us up. We will hook up Dr. Shibao as best we can. And also, we, in addition to funding research, we also do things like we write letters of support so that when researchers apply to the NIH for like a multi-million-dollar grant, we're giving them letters saying that this is a really important thing for our patient community, and we hope that NIH will fund it. So with that being said, let's get to some of these excellent questions. So people are asking if any of these diabetes or carbohydrate related drugs are currently being used to treat POTS. I think I know what you're going to say, but I think it's important to clarify that point.
No. No, none of the diabetes drugs that are available right now are used to treat POTS. So the majority, so I will tell you about what I have seen. And, it's very heartbreaking because we have patients that do not have any, any response to any of the drugs that we use, that they are very debilitating. And sometimes we just, try to do our best to understand the physiology of that unique patients and give some treatment. And sometimes it's a compassionate treatment, really. And among all the different treatments that are out there, you will see that there are reports of the use of octreotide, which is a somatostatin analog. It's an injection. And if you think about why it may work, and there are like 2 or 3 case reports out there, it's because it produces vasoconstriction in your splenic vascular bed, which is exactly what we think is a target organ for us when we look at, these specific hormones that are released after you eat. So even though, in general, we don't recommend the use of octreotide, you will see case reports in the literature for very sick patients in which this has been used as a compassionate use because, nothing else worked. And interestingly, it worked for some of them, right? But it's like a treating, it's like using a nuclear bomb to treat POTS because you pretty much shut down everything, right? So, and I think it will be important to provide evidence of what it may work based on the physiology, because we may not need to use that. We may need to use, an antagonist or selective, or we may need to use something that avoid the patient to take all these carbohydrates at once, right? So, but we need more research in this area so we can provide good advice.
Yeah. So I just share my little anecdote. I was misdiagnosed along like many patients with POTS. Early on, I was told I had a neuroendocrine type of cancer called carcinoid, which is treated with octreotide. So I was kept inpatient in the hospital and given octreotide, and I felt great, but I did not have neuroendocrine cancer, thank God. And as soon as they took me off the octreotide, I felt pretty awful again. But they didn't know I had POTS at the time. So they weren't going to offer me octreotide if they didn't think I had cancer. So anyways, there's a lot of other questions about glucose stuff. So do you suggest right now that POTS patients try to integrate a lower carbohydrate diet or focus on complex carbohydrates rather than sort of sugary junk food processed carbohydrates?
That's an excellent question. I think why not, right? These are changes that you can make in your routine. We usually advise that at Vanderbilt to try to eat small meals, less carbohydrates. I think it's something that you can try on your own. Complex carbohydrate versus simple carbohydrate. I think that it makes sense because the simple carbohydrates are immediately absorbed, right? And immediately produce amounts of a response in terms of your gastrointestinal hormone secretion. Whereas complex carbohydrate, you need to have enzymes in your gut that break down this carbohydrate into sugar or glucose to be absorbed. So the peak of insulin, the peak of all these different gastrointestinal hormones is less. It's more like it's blunted. It's there, but it's blunted. So it makes sense from the physiological standpoint, right? But we haven't tested that. It will be nice to do that, but like I said before, there are multiple questions that need to be answered, but it's not harmful to try.
Yeah. Do you see elevated A1C or prediabetes in any of these patients?
Yes, we do. We do see prediabetes. Now, one of the things that I would advise is that if you just, if you check your sugar levels fasting without eating the next morning, and it's normal, that in terms of POTS, that may not, mean that you actually don't have impaired glucose tolerance, because the majority of the impairment that we saw is not on the fasting glucose level, but the postprandial one or after the glucose challenge. So if you remember my slide, when we look at obese and POTS patients, the obese subject were like 90, 100. POTS patients were always 80. But then when we challenge both population, then the glucose level were at the same level, up at the same time, right? So so I would advise you to talk to your doctor. If you have especially family history of diabetes, get a fasting glucose. And you can also get a hemoglobin 1AC that give you an idea of your average glucose level. It's less likely that they're going to offer you a oral glucose tolerance test unless you're pregnant, because that's not usually used, although diabetes is diagnosed based on that. But if your hemoglobin hemoglobin 1AC is about 5.6, then I will definitely encourage you to talk to your provider. Okay.
We just had a great talk from Dr. Roy Freeman on autonomic neuropathies and diabetes. So we know that a subset of POTS patients have a small fiber neuropathy. Do you think that there is possibly a relationship between this glucose dysregulation you've found and the small fiber neuropathy that we're seeing in some POTS patients?
It could be. What I know about the small fiber neuropathy is that, for example, it's very prevalent even in obese patients that have impaired glucose tolerance. So why not in patients with POTS? Now, it won't explain why there is a much higher prevalence in POTS patients, right?
So there were some questions when you had presented the slides on the lean women with POTS compared to obese patients. So I think some people were confused and thinking that you were saying that you can't be obese and have POTS. So I'm sure I just wanted to clarify that because I see it a bunch
Oh, no, sure.
of
No,
course
I mean,
have POTS at any weight. But,
you can have POTS at any weight. So this is not about you do have or you don't have POTS. The obese women that I studied were obese, in other words, healthy in the sense that they did not have diabetes, and they were used as a control group for my patient with POTS. Okay, they were lean, and the reason why we did this is because you know, from the scientific standpoint, you want to control for all the variables that can affect the interpretation of your study, right? If I were to enroll patients that have POTS, but that has a BMI over the number of 25, in other words, obese, then you won't know whether it's really the obesity or the POTS that is causing the impaired glucose tolerance. So that's a reason from, you know, an investigation scientific standpoint, you want to be able to, you know, you select your population so you can test a hypothesis. It's not really to say, I mean, if you're obese, you don't have POTS. It's just that we use obesity as a control group and we use lean POTS patients just to study the physiology without the confounding effect of, you know, weight.
mm-hmm. You had mentioned in your slides that one of the possible mechanisms would be that the muscle fibers might not be using the glucose as efficiently as they should. Is anyone studying this? And could this explain why so many patients with POTS have real difficulty doing exercise?
Well, so it could be possible that from the muscle standpoint, things are not going as well as, you know, what happened in, you know, people who do not have POTS, right? Either lean or obese. Why? It's because of very simple phenomenon. So if your sympathetic activity is elevated, what do you think is going to happen with your blood vessels? They're going to shrink, right? In the muscle. So because it produces vasoconstriction. And how do you think, you know, glucose gets into your muscle? It's through the little blood vessel, right? So if your sympathetic activity is elevated and you vasoconstrict, so the flow into your muscle for the nutrient flux, for the glucose to get inside the muscle will be less. And that's, you know, a phenomenon that we call insulin resistant, which, you know, that can cause insulin resistant, which means that, you know, you need more insulin to get the glucose inside your muscle because your blood vessels are small. And that could predispose you to have a pre-diabetes state. Now, would that explain why, if you're doing exercise, you have muscle fatigue? I don't know. That's a very good question because in case of the muscle, when you are exercising your muscle, you don't depend on the glucose, or you do depend on the free fatty acid to, you know, generate energy. So it's a completely different metabolic processes that we haven't studied yet.
Someone's asking, in your slides, you mentioned B cell dysfunction. Are you suggesting that there might be an immune pathway here? I'm not sure if you meant B cells related to like pancreas cells or B cell immune cells.
Yeah. So let me give that clarification because I mean I put it next to the pancreas, but you know it's B cells. So the pancreas have alpha cells and B cells, and the B cells from the pancreas, those are the ones that secrete insulin. So when I talk about insulin beta cell dysfunction, it means that, you know, at some point your pancreas is not secreting that much insulin, right? And that happened in diabetes. Okay. So why? I mean, we think it's an inflammatory, you know, fibrotic process that affect the pancreas. So at some point, you know, you're obese and you become insulin resistant. So your pancreas has to, you know, release more insulin. At some point, your pancreas is going to say, I'm done. Then it's when your glucose level goes up because your insulin levels, you know, cannot keep up with the degree of resistance. Okay. So that's what I mean by beta cell dysfunction in the pancreas.
So I think just to clarify for some people are more into the sciencey terms, you know, so there's a difference between beta cells in the pancreas, which are sometimes called B cells, and B cells that are like white blood cells that are part of your immune system. There's a lot of terms for different cells, but these are different. The other thing someone's asking here, so you had mentioned the ketogenic diet as a possible approach to dealing with this carbohydrate problem in POTS. Can you elaborate on that? Like, what does that mean? And how do you do that safely? Because there are people who sort of take it to the extreme and it can cause health problems.
I just use it as an example because if you look at the compound, the macronutrients of that particular diet, it's really like a modified Atkins diet because you are mostly consuming proteins, right? Proteins and, complex carbohydrates, maybe, and that's pretty much what is going to decrease the release of these gastrointestinal hormones because compared to just carbs. Now, how can you do it safely? I always encourage patients to talk to a nutritionist because the least that you want to have is to start in a ketonic process, like with the amount of, metabolic acidosis, because you're trying to reduce too much your carb intake. So somebody needs to monitor you. But definitely between a regular diet with very simple sugars to a high protein diet with complex carbohydrates, which you need carbohydrates, I will balance to the later, right?
So we have a question, and I don't think we have any research data on this, but it's still an interesting thought. So there's all this research going on that Vanderbilt has been part of too, looking at different adrenergic and muscarinic receptor antibodies. And these are antibodies that alter the way the autonomic nervous system works. Do you think that there might be a relationship between sort of autoimmunity in POTS and glucose dysregulation in POTS?
Well, I don't think that we have much evidence for that. So could be a relationship, maybe. A lot of these processes are very interrelated. And, I just mentioned increased sympathetic activity can produce or put you at risk for insulin resistance. And a lot of these antibodies is affecting, some of these important receptors. Now, how much they are affecting to produce a really metabolic dysregulation is something that needs to be studied.
Mm-hmm. Like the answer to pretty much everything, we need more research. So do you have any data or clinical expertise on vasoactive intestinal peptide VIP in POTS? Do you see anything similar to what you're seeing with the glucose dysregulation?
Well, that's an excellent question, actually. When we look at the panel of all the hormones that we measure, and we measure most of them, we measure glucagon, PYY, and pancreatic polypeptide. We didn't measure VIP. And VIP is a very important hormone for regulation of the splenic circulation. So when we submitted our grant to the NIH 2 weeks ago, we include that as part of our measurement.
Okay. Some patients are talking about having problems with hypoglycemia. So is that something you see commonly in dysautonomia patients or in POTS patients? And is there anything you do to work up those patients when you see that?
Yes. Well, so yes, I saw that regularly actually. And a lot of these patients are diagnosed with reactive hypoglycemia. And, unfortunately, some of our colleagues is like, well, reactive hypoglycemia really doesn't exist. But you can clearly see in these patients when these are usually patients that are lean, they have significant sympathetic activity, and that, the blood sugar drops to sometimes 50, and it's symptomatic. So they sweat and they have their typical hypoglycemic symptoms. So usually once again, you have to eat your proteins. You cannot just eat carbs. The carbs cannot be just simple carbs. It has to be complex carbohydrate because the hypoglycemia is related to the fact that the insulin is released in a very fast pace, in a very high quantity. So you have to reduce that by, changing your eating habits. And how do you work up? Well, the most concerning thing that I can think of is there are sometimes tumor in the pancreas that produces a lot of insulin. And you have to do special testing in collaboration with your endocrinologist to rule out that. Because these tumors, actually the insulin is secreted independent of whether you're eating or not. They just, they're secreted. And the best way to catch that is when the person is not eating and you can, determine that your blood glucose level is still falling, okay? So this patient eat all the time because they think that their glucose level is going to tank. But that particular disease is very rare, and you have to work this out with your endocrinologist. When you tell your endocrinologist with your glucose level that is low, then they will work that out. And it's rare, but can happen.
So are there, so in your study that you showed the data on with the acetaminophen, those patients didn't have any significant motility problems, gastrointestinal motility. But there is research on POTS patients from other centers showing that a good percentage of them do have altered gastrointestinal motility. Can you talk about how altered GI motility would possibly contribute to glucose dysregulation problems?
Well, definitely, I mean, the gastrointestinal motility is very important because that determines the rate where the nutrients are going to be delivered to the small intestine, right? Where it's going to be absorbed. So just a couple of things. What we gave them was a glucola, which is just, a little bottle with just a lot of sugar. So gastric emptying, delayed gastric emptying, or any gastric motility alteration happen when you eat a meal. It's different. The composition is different. And the reason why we use the acetaminophen is not to diagnose gastric delayed gastric emptying. It was to be sure that absorption between two groups are not different. So there's an important concept there. Okay, and yes, we did a review 2 years ago. We wrote it about, different gastrointestinal problems in patients with POTS, and you have both. You have gastric delay emptying and an increase in the motility with, the presentation of diarrhea sometimes, not so much the decreased gastric emptying. So it's a very, it is not clear cut. Mm-hmm. And some patients even go from one to the other. It's like they bounce from from having gastric delay emptying to an increase in the motility, right?
Since your data had showed that about half of POTS patients have impaired glucose tolerance, how would a patient talk to their doctor about that if they wanted to? Are there certain tests they should ask for to make sure that everything's okay? Or, is there a good way to talk to a doctor about this? Because presumably, unless our doctor happens to work at Vanderbilt, they're not going to know about this in POTS patients. It's so new.
Well, first of all, you need to always look at your family history. If you have a family history in which, you have your mother, father, or close relative with type 2 diabetes or type 1, you definitely need to check your glucose level, okay? Especially if your weight is over the BMI of 35, or 30, not 35, which is obesity. So that's one. There are other conditions that put you at risk from impaired glucose tolerance, like sleep apnea, for example. That's another thing that you need to consider. And third is the typical testing for diabetes is fasting glucose level and hemoglobin 1AC. I just wouldn't do only the fasting glucose level because, as I said before, it's always normal. Hemoglobin 1AC will be a very good method, and the best will be a glucose tolerance test. Okay.
Great. Thank you so much, Dr. Shibao. That was really, really awesome. And I'm so excited that this research is happening because I think it's going to help advance what we can do to help treat POTS.